So, welcome everybody to the Global Health and Education webinar on exploring global inequalities in adolescent health and healthcare. My name is Goof Buys. I'm the manager of the UNESCO Chair and WHO Collaborating Center on Global Health and Education. And I see that still people are coming in, but we will start anyway. It's going to be an interactive webinar held in the English language, obviously, and the webinar is very topical. It's during International Adolescent Health Week, and we are very happy to have two excellent speakers with us in this webinar, and also an introduction by Professor Sir Michael Marmot. I think that the introduction will, by our speakers, will be combined with questions that you can send. You can ask your questions using the Q&A, which is at the bottom of your screen. And you can see there is already one question put in that box. Please do so. And during the webinar, we will take care that our speakers will come back to these questions. And I would like now to introduce Professor Sir Michael Marmot. We're very lucky to have him also in our webinar. He was not able to join live, but he recorded a short video which is about the paradox about adolescence. Sir Michael Marmot is a well-known professor of epidemiology and public health at the University College in London. He is current director of the Institute of Health Equity and one of the world's leading experts in this field. So we're really happy to share his talk with you, which will speak for itself about what I already said, the paradox about adolescence. For young people, it's the most relevant time. For professionals, we tend to focus more other parts of the livelihood. So please, Sylvia, my colleague, can you start the video?
There's a curious paradox about adolescence. For young people themselves, it is the most intense time of their lives when everything seems to be up for grabs and happening. For people who are concerned with health and health inequalities, they somehow forget adolescence. They focus on maternal and child health. They focus on early child development, what happens in the first 5 years of life. Yeah, education's important, but then having said education's important, they move on to adult life and older life. And what happens in between? So we've got this intense time of importance to young people that tends to get ignored, which is terrible. I think of adolescence as such a crucial time because it's a reflection both of causes and consequences. The causes come before maternal and child health, early childhood, have a big impact on what happens during adolescence. And what happens during adolescence is a cause of what comes subsequently. So it's a consequence of earlier influences and it's a cause of subsequent influences, and it's important in and of itself. Think about school performance. In Britain, we show this dramatic social gradient in performance at GCSEs, the national exam young people do at age 15 and 16. The more deprived the area, the worse the school performance. Think about mental illness. again, we see it, well-being. Not only do we see the gradient, in the UK, according to UNICEF's report card, out of 36 rich countries, the UK ranks 27th on childhood well-being. The US ranks 36th out of 38, one being the best. Childhood well-being, which includes the adolescent period, is appalling. Are we paying enough attention to it? I've drawn attention to the rise in violent crime among adolescents. It follows the social gradient. It went down for a bit and then went up. Is that related to the cuts in services for adolescents? What about young people not in employment, education, or training? NEET. Now, that tends to be 18 to 24-year-olds, but it's a consequence of what happens in adolescence. All of this is of vital importance. All of it tends to show social gradients. The more deprived, the greater the problems. And it's been too little studied. It's an area of vital importance. If we want to look at inequalities in health through the life course, we need to start with preconception, conception, pregnancy, birth, early childhood, and then this other crucial development period of adolescence, because it sets the stage for what happens subsequently. So to repeat, inequalities in various important outcomes, including health in adolescence, are of vital importance. But so is adolescence important for understanding what came before and what comes after. So looking at mental health at this time of life is vital. Looking at it in the context of inequalities has the potential to make a major contribution to improving health equity.
This was Sir Michael Marmot setting the scene, and I'm sure the two speakers, Susan Sawyer and Danielle Jansen, will take stock of his observation. Are we paying enough attention to adolescents in their talks? I'm sharing my screen now. And the first speaker will be Professor Susan Sawyer, and she will speak about what do we know about global inequalities in adolescent health outcomes. First, a short introduction. Professor Susan Sawyer holds the chair of adolescent health at the University of Melbourne. She is the director of the Centre of Adolescent Health at the Royal Children's Hospital there in Australia. She's a pediatrician, and her efforts help to extend global understanding of importance of adolescents and their health and well-being. She's also an active researcher and, amongst others, currently the president of the International Association of Adolescent Health, with whom we are organizing this webinar. I asked both speakers if they had any good memory to share of her adolescence time herself, because that's the thing we all have in common here, united in this webinar. We all were adolescents. One thing that she shares is that moving with her family in early adolescence from the city to a farm was a difference as big as she felt when she lived in Japan for 1 year as an older teenager. Susan, I'm happy to give the floor to you. Susan, sorry.
Yeah.
I forgot to say about the WooClap question. Can you stop sharing? I will share my screen.
I can stop sharing.
That's my mistake. So while Susan is talking, we'll ask you also as audience to this webinar a question, and we have the WooClap tool for that. And the question is, what is the benefit cost ratio, in your opinion, of investing in adolescent health? And for WooClap, you have the Q&R code that you can see on the screen. You can also access via internet by connecting to www.wooclap.com/25th March 2021, and you can directly participate and give your answer. Or you can also use SMS if this doesn't work, and send at 25th March 2021 to the phone number 0644609662, so you can participate. So having said that, I'll switch back to Susan.
Okay, it says I can't screen. Okay.
You can now.
Can you see that all right?
Sure, it's good.
Thanks very much, Hoff, and warm regards to you all. Yeah, moving to the country when I was 12 from Melbourne was a huge shock to the system. And again, that notion of the different cultures of adolescence that I think Danielle might pick up later. But I think, as Sir Michael Marmot said, that adolescents have been neglected. They have been disadvantaged. They have least access to mental health services of any age group. And they have greatest use of unsafe abortion. So whether we're talking about mental health or sexual health, just two examples here. And when we ask health professionals, what population group are you most challenged by? Study after study tells us that it's adolescents. I put this data up to also suggest that adolescents are disadvantaged. This is a study from Russell Viner in the UK looking at 50-year mortality trends, all-cause mortality trends. And if you just focus on the top panel, which is looking at male mortality in under 25-year-olds, I've highlighted in purple the dramatically impressive 80% reductions in mortality in 1 to 4-year-olds, in comparison to the flatlining of blue in 15 to 19-year-old males, a pattern that's replicated in females. So inequalities across different populations, and obviously in terms of COVID-19, and we're experiencing inequalities in terms of age in a different way. Now, why isn't my screen going? So another question to you in terms of inequalities. In the past 10 years, what proportion of research do you think has been undertaken in under 5-year-olds versus 10 to 19-year-old adolescents? It's only 5 years versus 10 years of adolescence. So is it about 50%, 45% of research, 75, or might it even be as disproportionate as 95%? The actual answer is 95%, or indeed, depending on which search engine you look at, actually 99%. So in terms of in unequal investments in research, certainly adolescents have missed out. Now, the definition of adolescence we used in the Lancet Commission for Adolescent Health that was published in 2016 was this period of time where it was a profound period of human growth and development in which the assets and capabilities that underpin future adult health and wellbeing, social relationships, parenting and employment are established. This is a very different definition to perhaps the definition that I grew up with as a medical student, if I'd been taught anything about adolescence, but I don't actually think I was, this brief period of turmoil to one which we now recognise as a foundation for future health. And in terms of that question from Aaron Deep, in terms of the age definition of adolescence, WHO's current definition is 10 to 19. But certainly in the Lancet Commission, the definition that we used was a much more extensive definition, which is increasingly being used from 10 through to 24 in recognition that so many of those life transitions indeed are extending into the third decade of life. But I've also put up this quote from the front cover, or highlighted it here, about adolescence as this transformative period, both in the life course of us as individuals, but transformative in terms of the health and wealth of nations. Some of you may have heard this notion of the triple dividend, and it's a different way of, in effect, explaining what Sir Michael Marmot started his terrific introduction with in terms of thinking about causes and consequences. I refer to this as the butterfly diagram. This comes from the Lancet Commission. And if we think of the horizontal line in the body of our butterfly, we can see those, if you like, life course trajectory from preconception through into adolescence, adulthood, and then around into the next generation. And I don't think of as adolescence as the end of childhood, but I actually think of adolescence as the start of the next generation. And if indeed we are wanting the best start to life in the next generation, then investing in adolescence is where it starts. It's too late to think about, if you like, preconception health. But in terms of the wings of our butterfly, they meet ideally such that the actions that are put in place at a national level, at a local level, are matched to the needs in a population, whether those needs relate to health problems, whether they are health risks, or indeed whether they're larger determinants of health. In the Lancet Commission, what we did in terms of thinking about health needs at a country level was that we calculated and summed all of the ICD-9 codes, back then I think it was, so these 9 groups of disorders, and we combined the burden of disease into these 3 broad groupings of diseases of poverty, injuries, including violence, and non-communicable diseases. And then country by country, we grouped countries according to where their excess burden was. And you can appreciate that as we move from left to right here towards non-communicable diseases, we are seeing a different pattern, what is referred to as the epidemiological transition. This is a slightly complicated diagram, but I'm going to take you through it. The reverse pattern is here. So if you like, NCD predominant countries are the 2 panels on the left, females and males, injury excess in the middle, again, females and males, and multi-burden on the right. And this is the change in the burden of disease, so disability adjusted life years using model data from IHME from 1990 through to 2023. And what you can see in multi-burden countries on the far right here is this excess burden from HIV, infectious diseases, sexual and reproductive health, this is particularly maternal mortality, and undernutrition. And you can see that there have been some substantial improvements. In the middle, you can see a disproportionate burden, not from those types of conditions. These countries have managed to get on top of these conditions, but we can see this heavy burden of violence and injury related morbidity and mortality that is particularly pronounced in young men. And then in all countries, we can see this green swathe underneath of chronic physical disorders in dark green and mental disorders in pale green. So straight away, we can see the inequalities here of appreciating that there is double the burden of health, if you like, in multi-burden countries in adolescence versus NCD predominant countries. So a question to ask you, another question. In the past 25 years, has the scale of health problems in adolescence got better or has it got worse? I'm using this data from Peter Azzopardi to demonstrate this. If we look at 1990 in comparison to 2016, we can see that many more countries in 2016 are green or NCD predominant countries with a better disease burden, if you like, than the multi-burden countries. And indeed, back in 1990, only 16% of countries were NCD predominant, and now in 2016, 45% of countries are NCD predominant. So of those of you who answered yes, that the health burden is getting better, you're right. However, for those of you who have said it's getting worse, you are also right. Why might that be? Demography is the answer. If we go back here for a minute, we can see that where the population is greatest in young people is in sub-Saharan Africa and South Asia, the Indian subcontinent. And what we can appreciate then in terms of the growth of those populations of adolescents, that from 1990 through to 2016, there has been a disproportionate growth in the number of adolescents growing up in the world. Indeed, 250 more adolescents growing up in the world, or 35% increase in 2016 to 1990. So in that sense, the number of adolescents growing up in the worst disease pattern has got worse, not better. But as Danielle's going to be highlighting, there are major within-country disparities. And I simply put up this panel again, also led by Peter Azzopardi, looking at differences in Australia, my own country, looking at a dreadful record of the effect on health of dispossession, of colonial trauma, on education, labour force participation, parenthood in young women, whether we're comparing non-Indigenous Australians in blue versus Indigenous Australian adolescents in green. And similarly, we see double the deaths in all ages, 10 to 14, 15 to 19, to 24, in Indigenous versus non-Indigenous adolescents. So whether we're talking about LGBTI status, whether we're talking about immigrant populations, whether we're talking about Indigenous populations or low SES, we see a very disproportionate burden. So we might think if we've got disproportionate research and disproportionate burdens, we might have greater investment, what is known as developmental assistance. So my final question here to you is, what proportion of developmental assistance goes to adolescents? So developmental assistance is what is supported in countries who are poor and need additional income. Those countries have about 30% of their population being young in the age from 10 to 24. So we might think perhaps proportionately we should be investing 30% of developmental assistance going to adolescents. You might think it's 13% because 13% of the disease burden in these countries has been modelled to be from adolescents. Or is it very low? Is it, say, 2%? Those of you who think it's very low are right. The actual answer is 1.6%. So again, inequities of research investment, inequity in terms of developmental assistance. So what do we need to do to reduce global inequalities in adolescent health? As far as I'm concerned, we need investment here. Investment in adolescent appropriate policies and programs, investment in research so we actually know what they are, and investment in professional education and training, because this is where, in the absence of critical mass and in the absence of a change in mindset, we will just keep doing more of the same, that is, neglecting adolescents. In terms of that, as president of the International Association for Adolescent Health, I would warmly invite you to join and contribute yourselves to that critical mass, be part of a movement with young people themselves to be aiming to reduce some of those global inequalities. Thank you very much.
Thank you so much, Susan, for your very concise and inspiring talk about why it is so relevant to pay more attention to adolescent health. And as you said, adolescence is the foundation for future health, not only of individuals, but of the health and wealth of nations and society as a whole. So I'm just checking. There is a question, Sylvia. Are there any questions in the chat or in the Q&A?
Yes, thank you, Goof. There's a question in the chat, and that's how has COVID-19 impacted these global inequalities for adolescents?
It's a really powerful question. You know, I think we're all aware, as I was sort of alluding to, that the oldest in our populations, people of my mother's age in her 90s, are those who are most at risk of the direct effects of death from COVID-19. But clearly, in terms of those indirect effects, in terms of impact on schooling in particular, and in terms of mental disorder, there is no doubt that the impact of COVID-19 has been extreme. And if there's one further point I would make here, I think that in terms of those notions of the triple dividend, the other aspect of this that I think we really risk seeing during this pandemic without thinking very intentionally about it is what is referred to as intergenerational scarring. That is the risk that comes from a cohort of young people who as a group are exposed. So we know that at times of major unemployment, the depression, the Great Depression, for example, the 2009 financial crisis, that there are great cohorts of young people who, in terms of interruption to their education, to the quality of their training experiences, that the impact of this risk staying with this cohort of young people across their careers, which for me is another reason to be really trying to think about how are we making sure that we're appropriately investing and what are the types of investments that need to be made to try to mitigate that potential life course scarring.
Okay, thank you very much. Are there more questions, Sylvia, from our audience?
Yes, thank you. I've received another question. That is, what are the priorities in terms of political changes in order to improve adolescents' health?
I think there are many political changes here. Perhaps one of them is actually appreciating that we need to be listening to young people themselves as being part of the contribution to forming their own solutions and really helping us in the Lancet. We sort of talked about needing to learn how to listen to young people as much as we need to be supporting young people to contribute their voices within the political arena. And in that sense, it's particularly challenging because so many young people don't vote. And so why would politicians listen to young people without them being able to vote? But I think this is where young people increasingly around the world are demanding that their voices are heard. And I think that this is something that we should be very much supporting young people doing that in ways that are safe for them, rather than in ways that risk getting them into trouble. And this is where I think that professional associations and groups can be very powerful in terms of trying to ensure that young people are able to own their voices, contribute those voices within their communities and populations, but in ways that are safe for them. I was very sobered a number of years ago when we launched we had a launch in Lebanon of the Arab edition of the Lancet Commission for Adolescent Health. And there was a group of young activists on stage, and Professor Rima Afifi was basically saying that the activists from 10 years ago are not here. Why? Because they're either all in jail or they're dead.
Yeah.
I found it incredibly sobering in so many countries where the political context is not one which is welcoming of young people, and therefore we do need to find ways as adults of trying to be promoting safety whilst young people are achieving the contribution of that voice.
Thank you very much, Susan. And I'd like to let you see what the results are of the WOOC Lab. The WOOC Lab question, which was, what is the benefit cost ratio investing in adolescent health, Sylvia? So here is the scores.
Brilliant. Okay.
So, what can you say?
I'm impressed.
Okay.
So can I, that the majority of respondents have clearly said more than 2. So can I share my screen and show you where these data come from and where that question comes from, which is by a paper from Peter Sheehan published in the Lancet in 2017. And this was looking at benefit cost ratios for a suite of investments. In government speak, that a BCR higher than 2 or higher is considered a good investment. So this means that for every dollar you invest, you get a 2-fold return. And for those of the 2/3 of you who said that the benefit cost ratio was 10, you're absolutely correct that when we combine the investments that are made to improve health outcomes, continuing participation in education, reductions in road traffic accidents and injuries, and promoting child marriage, overall the benefit is 10. And on the right, what is particularly important to appreciate is that the poorer the country, the greater the benefit cost ratio. So I think that it's pretty important in terms of having a set of arguments in our pockets to be able to take out to politicians. Taking young people with us is one of the most powerful ways we can be influencing politicians, but speaking their language about the value of investing in adolescents, I think is equally powerful.
Okay.
Thank you very much.
Thank you very much, Susan, and I'll thank you for your contribution. You'll be back after Danielle Jansen will do her talk, and I'm now. Oh yes, there's a comment in the chat that every all the presentations and a lot more information will be available on the dedicated webpage of the webinar. And now we will move to Danielle and share my screen to make clear the question we ask Danielle. Danielle Jansen, oops, that's too fast. Which health service barriers linked to health inequalities do adolescents experience in Europe? And before Danielle will take the floor, I have the pleasure to briefly introduce her to you. Danielle is currently Associate Professor at the University of Groningen in the Netherlands, and also at the University Medical Center in Groningen. She's a medical sociologist by background and internationally active in the European Public Health Association, the EUPHA, who is also the co-organizer of this webinar of the section Child and Adolescent Health. She was president there for 7 years, and now she is a member of the steering committee. Her research focuses on children and adolescents in the Netherlands and in the European region, focus on health and social care and health systems. Her research is multidisciplinary, which you will find out soon, and focusing on primary health care. And in these COVID times, she advocates for the best outcomes for every child and adolescent. And asking Danielle a good memory of her adolescent time, she said, growing up in one of the Dutch polders, she worked during her summer vacations at a farm. This taught her discipline and fun at the same time, and between brackets, earning some money. Danielle, the floor is yours.
Yes.
Oh, I have to also ask the book lab question.
Yes.
Yeah, sorry. The second book lab question is, what are the most common health system barriers that vulnerable adolescents experience? So again, we encourage you to go to the book lab, and it's how you get there will also be on the chat. And now we quickly move to Danielle to do her presentation. Danielle?
Yes. I think you see my screen now.
Yes, it's working.
Okay. Hello, everybody. I start my presentation by first explaining what health system barriers are. Health system barriers are those barriers that affect the delivery, the service delivery system. And these barriers are associated with the structure and processes of service delivery. One framework with which we can highlight the essential components of a health system in which barriers and enablers are operating is the WHO Health System Framework. This very well-known and instrumental framework has been widely applied across the globe and describes 6 core components or building blocks. You can see them at the left of the slide. These are service delivery, health workforce, information, the availability of medical products, vaccine and technologies, financing, and leadership and governance. And these building blocks high in the access and improve the coverage, quality and safety, and at the end lead to improved health outcomes. Strengthening the health system means improving these 6 health system building blocks and managing their interactions in ways that achieve more equitable and sustained improvements across health systems and health outcomes. The WHO Health System Framework can be applied to improve the overall population health in a responsive, financially fair and most efficient way. And incorporated are the vital indicators addressing health inequities, namely availability, accessibility, affordability, and quality. So who are the vulnerable or the underserved adolescents? Underserved populations are those who have been shown to have disparities in access to care and in health status. There are many categories of underserved adolescents, and on this slide I do not provide an exhaustive list of underserved adolescents, but my main aim is to give you an impression. First of all, adolescents with an immigration background. For example, the first and second generation adolescent migrants in the Netherlands, which means that they are born abroad or born in the Netherlands and having at least one parent that was born abroad. Second, adolescents with a low socioeconomic status. And third, adolescents from ethnic minority groups such as the Roma in Central Europe. And in her presentation, Susan already mentioned the indigenous population. And although indigenous populations are not the same as ethnic minority groups, they often share a history of exclusion and discrimination based on identity, and which led to high levels of poverty among them. So now you know at what level health system barriers can be found, and you know some of the underserved adolescents. And I will now share some information on experienced health system barriers linked to health inequalities in adolescents in Europe. And I will do that based on information of two projects. One is the soon to be started Horizon 2020 project, RIVER EU. RIVER stands for Reducing Inequalities in Vaccine Uptake in the European Region, Engaging Underserved Communities. The other project is MOCA. It stands for Models of Child Health Appraised. And in this project, we explored primary healthcare for children and adolescents in 30 European countries. In this table, you see the countries with underserved populations we have chosen for our RIVER EU project. We choose these vary for different countries and populations because they experience a low measles or HPV vaccine uptake compared to national uptake. And these populations also experience barriers in immunization health systems that contribute to the low uptake. And finally, we chose these countries and populations because our partners in those countries do have strong connections with the government, with the most important national stakeholders, and with the underserved populations themselves, which is necessary to engage them in the research. And in this table, you see the WHO building blocks, and per country, which barriers in the building blocks are established. And you see in the Netherlands, we have, well, only two barriers found, and Slovakia has barriers in 4 of the WHO building blocks. The first experienced health system barrier is the lack of reliable documentation and health information system. In Greece, Poland, and Slovakia, there's a lack of documentation of vaccination and medical history of the underserved adolescents, which is necessary to understand and compare data and for taking action if needed. In addition, in some cases, the adolescents do possess false immunization certificates. The second health system barriers are the experienced challenges in accessing credible online vaccination information in native language. This was the case in the Ukrainian migrant adolescents in Poland. The third health system barriers are intercultural communication difficulties. Many underserved adolescents experience barriers in communication with healthcare professionals, and these barriers often result in the indirect unavailability of vaccination services. The fourth health system barrier is the lack of well-trained and well-equipped staff. Many Turkish and Moroccan adolescent girls and their parents in the Netherlands have negative beliefs and attitudes about HPV vaccine safety and effectiveness. They have the conviction that HPV vaccines can be extremely harmful, which lead parents and female adolescents to refuse or delay vaccination for HPV. Until now, staff in the Dutch health system is not trained well enough to address the HPV vaccination beliefs and attitudes of these adolescents and their parents. The fifth health system barrier was the absence of a doctor to approach when needed. Especially in the Roma settlements in Slovakia, there is no doctor available, which hinders the path to further services. The sixth experienced health system barrier concerns the high cost of vaccines and transports to vaccine services. Self-paid HPV vaccines are not of interest for people living in Ukraine, as well as for the Ukrainian migrants to Poland, due to the high costs. In Slovakia, the lack of governmental financial resources leads to disruptions of programs focusing on the improvement of Roma health, also related to vaccine preventable diseases. Transport and medical costs are additional barriers to accessing healthcare services. Among the Slovak Roma community, over 9% could not afford or did not want to pay a fee for immunization. A seventh health system barrier is the link with immigration authorities. Adolescent migrants without documents in Greece are discouraged from accessing government-associated health services because of the links with immigration authorities. And a final health system barrier in one of the 4 selected populations was discrimination. The discriminative attitude of some healthcare professionals in Slovakia prevents adolescents of the Roma population from seeking help. In the coming minutes, I will tell you more about experienced health system barriers linked to inequity in adolescence in Europe. These are the health system barriers related to primary mental health services, sexual and reproductive health services, and school health services. On this slide, I'm showing the experienced health system barriers in primary mental health services. The first barrier is lack of professionals trained in intercultural issues. Adolescents having migrated recently, with or without being accompanied by the parents, often need expert professionals trained in intercultural issues. Only one of the included European countries, Slovenia, had such a professional throughout the whole country. In another 18 countries, it was the case in some parts of the country, mainly in large cities. In other words, in 12 of the 30 countries, there were no such professionals available at all. The second health system barrier is the absence of a translator. One simple way to assist primary healthcare professionals is to provide translation. In only 18 of the 30 countries were such translators available when needed. The third barrier is payment of services. In several countries, co-payment for mental health services existed up to the age of 18 years. In five countries, adolescents or their parents did have to co-pay in specific situations or circumstances, such as long-term outpatient psychotherapy, receiving additional services during hospital treatment, or being referred to a psychologist. I'm sorry. On this slide, I'm showing the experienced health system barriers in sexual and reproductive health services. The first 2 barriers are related to payment of services. In only 11 of the 30 countries, oral contraception is free of charge, but often under certain conditions, for example, at a reduced price from 18 to 20 years of age. In several countries, termination of a teenage pregnancy is covered by the insurance company, while in other countries, the expenses have to be covered by the adolescent's parents. The third barrier is related to privacy and autonomy of the adolescent. In some instances, the situation of a minor adolescent may require the termination of the pregnancy without the parents knowing. This may, for instance, occur when there is a risk for the adolescent being forced to marry or being sent back to her country of origin, or when there is a risk of the girl being molested or seriously beaten by her relatives. And we also had done some research 10 years ago, and to a large extent, our results show that little has changed since 10 years ago. So these barriers I am now mentioning were also the barriers that existed already for 10 years. On this slide, I'm showing the experienced health system barriers in school health services. On the question, what should be improved in school health services, 14 of the 30 countries reported that inequalities in access to school health services in the countries is an area that still should be improved. Finally, only 18 of the 30 countries had a policy to improve integration of adolescents in school and to encourage education of vulnerable pupils, but in 13 countries, no such policy existed. And not going to school means no access to school health services for these vulnerable adolescents. My conclusion, adolescents experience many health service barriers linked to health inequalities. And the experience barriers cover most, if not all, of the WHO building blocks. And these health service barriers lead to less access and more health problems. And we have sufficient starting points to start removing health system barriers. So I think it's time for action. You may never know what results come of your action, but if you do nothing, there will be no results at all. Thank you.
Thank you so much, Danielle, for your excellent presentation and of your quote. And I think you are the living proof of not doing anything. And I admire your patience and perseverance in the field that you are working. And I have one short question, and then we move to the WCLAB results of the WCLAB question. Mm-hmm. But how do you believe that COVID has affected these national inequalities, currently the last year?
I think that, and it's a quote or a sentence that you hear everywhere, that COVID has, showed us a mirror, and all the inequalities that already existed are now showing even more, are showed even more by COVID. So I think COVID shows to a bigger extent what the health inequalities are. And I think in COVID times, these are the same as in non-COVID times, only they are now more clear. And yes, that's also why I think we cannot neglect it anymore, and we should do something about it, just even now in these COVID times.
Sure. Thank you so much. Sylvia, can you share the screen to show the WCLAB results? What is the most common health system barrier?
Yes,
maybe Danielle,
it's about.
You can just reflect a little bit on it.
Yes. Well, I see in red in the middle of the word cloud, I see access, and I think that is one of the main problems in health systems, that the access is not equal for every adolescent. So that is one major point that should be addressed, and to improve access, you should focus on the WHO building blocks. And I see the structures, so that is one. In fact, all the building blocks on the left of my screen are make part of the structure of a health system. I see information, services. It's also accessing, delivering care. Systems. So I see a lot of parts that can be included in the building blocks. But what I also see is poverty. It's also rather big and central in the word cloud. And I agree that if you want to improve the health system, improving the health system is not the only determinant of good health. And I think investing in poverty is as important as investing in health systems.
Yeah, okay, thank you. Well, we will continue the discussion now with both speakers, Danielle and Susan, and we'll focus on the following question. I'll put it here for the audience to share. How can we use this knowledge to redesign national systems to minimize adolescent health inequalities? So I would like, first of all, to give the floor to Susan. Susan, to share your thoughts about this use of knowledge and the redesigning processes. Over to you.
Thanks, Hoff, and thanks, Danielle, for a lovely presentation. And I think it's really interesting to see how these presentations are fitted so well together in terms of that notion of inequality at a country by country level and then within a country. So I suppose I would like to take that big picture view first and really think about the role of poverty reduction and thinking about the sorts of social welfare policies that need to be put in place, that in so many countries, we've been lucky enough during this COVID pandemic to appreciate the impact of, in Britain, for example, I know you call it the furlough scheme, We've got a different language about it in Australia, but basically the level of unemployment benefit that is otherwise paid to people is much, much greater during COVID than it would be if otherwise people were unemployed. And I think that this has been so critical in terms of reducing poverty and promoting family health and well-being. So other, if you like, taxation levers, employment levers, welfare, financial benefits to families, not just with young children, as some countries provide financial relief, for example, to families where there's children under 5, under 10, under 15, but I would argue, under 21. And I think through those sorts of poverty reduction approaches, we know that we are also promoting gender inequality, if only that we know that the wealthier countries, and it's been studied well, that wealthier countries have less gender inequality, that in terms of some of the particular health impacts, both for men and women. So these aren't just in terms of negative impacts on women in terms of sort of hegemonic notions of masculinity, which are so damaging to men as well as women, but reducing gender inequality is important. And I think if there's one other thing I would say, so my second point would be about thinking differently about the role of schools. And again, in this pandemic time, I just really want to come back to how much we've learned about the importance of schools in terms of sites for learning outcomes. And I know that those of you in the UNESCO framework are absolutely focused around the importance of schools in terms of what they achieve in terms of those outcomes that promote quality learning, which is so important in terms of future economic income for us as individuals. So on one hand, it's thinking about promoting those core building blocks within teacher education that promotes better quality teachers, but also then recognizing the broader role of schools as social communities where young people meet, in which health, particularly mental health, in terms of well-being, is actually achieved within that social environment. And then again, I mentioned it on my last slide, but the notion of investing in workforce education and training as a mechanism of building critical mass, changing mindset. As a young doctor, I knew really nothing about adolescent health. I had no training whatsoever. I would like to hope now that the students that I train as medical students at the University of Melbourne or students around the world are in a very different position, whether they're going to be going into public health, whether they're going to be going into clinical roles, or whether they might be influencing policy development.
Yeah. Okay, thank you very much. And I would like to ask the same question to you, Danielle. How can we use this knowledge for our national systems?
Yes, thank you, Goof. I said it's time to undertake some actions, and we already know quite a lot, but for starting, I think we have to prioritize where to focus on, because it's not possible to improve the whole system in one. So we have to take step by step, and by doing that, prioritizing the focus of change, I would suggest to involve the underserved populations. Involve the underserved adolescents in this case, to find out which health system barriers they experience. And we know the most common health system barriers, but we also know that in some cases they experience barriers that we don't think of, that are not in our mind. To know what really matters, I think we first have to start by involving the underserved adolescents. Second is that there are some countries and some populations. In our project, we call it the positive deviance. And these are also populations that, based on their description and definition, they are prone to be underserved. But they are not underserved because they receive the right care at the right moment. So there are some examples from, potential underserved populations that are not underserved, for example, for vaccination services. So we can learn from that and find out what happens in those populations so that these populations have a high vaccine uptake, for example. And the third point that I would focus on is the kind of research that we can do in order to implement and evaluate health system changes. I'm a very big fan of participatory action research, which means that you try to implement something, an intervention in the underserved community. And you make the underserved community part of your research team and also let them decide what the preferred outcomes are. And then you evaluate what you are implementing, and together with the underserved community, but also with the healthcare professional, you try by improving in a cycle by improving and evaluating to come to the best possible intervention. So these 3 points, I think we should start with.
Okay. So there's a call for action at the end of this webinar. Yes. Thank you so much, Danielle. And I wanted to check with Sylvia, did you get any comments or feedback on the chat, or please?
Yes, there's a question in the Q&A, and that is, what is the approach of WHO about these problems?
So who would like to answer that, Susan and then Danielle, because you're both very
Danielle,
closely
do you want
affiliated.
to go first in terms of just your comments around sort of health services or things like that?
Yes, I can. The WHO is, with several initiatives busy with health system improvement. They were closely connected to the MOCA research, in which I had a very important role in the advisory board. And they will also join the advisory board of the New Horizon 2020 project. But I'm also involved in an initiative in which we want to find out which health system disruptions are now taking place in times of COVID. So first, try to find out which health system disruptions there are and what the outcomes are, so we can undertake action. So, I know that they are on different levels busy with starting to improve health system. What I see is that the main point is the shortage of data, outcome data, but also process data. So we know a lot, but there's also little data to know enough.
Yeah.
Just to add to that, one of the exciting things that will be coming out later this year in May are new clinical guidelines that WHO has led on school health services, which I think, Danielle, in terms of the comments that you made in Europe about the variation in access to health services at a country level is really important. The other work that I confess a slight conflict of interest because I've been engaged in it personally is in relationship to new global standards for health promoting schools that are similarly going to be released at the World Health Assembly in May, which for the first time is really providing this sort of broader framework of what might be able to be measured by countries in terms of really thinking about that whole school approach, with school health services being one of those global standards. So again, I think really timely work for WHO in the context of the pandemic and the impact in terms of both children and particularly adolescents' participation in education and training, and the closure of schools and the potential impact both for educational transitions as well as for impact on health outcomes.
Yeah. And Sylvia, were there more questions from the audience?
Thank you, Goof. No, at the moment I do not have any questions left.
Okay. So then we can...
Perfect timing.
Perfect timing.
Yes,
I think
it is.
I think we are at the end of our webinar, and I think if you were not already, this is a wake-up call for how important it is to work on adolescent health. And also the message was with adolescents, so involve them, listen to them, what are their needs, and how can we, make use of that, do more research, and see how we can prioritize the work. And we have two pioneers, Susan and Danielle, working in this field to help us with that. So thank you very much on behalf of the audience and on behalf of the UNESCO chair, both Danielle and Susan. And also I want to thank Nicola Gray, who is associate researcher for the UNESCO chair, in bringing all these excellent people together and providing input for this webinar. The webinar video will be available on our dedicated webpage that you will all receive, together with the summary of the presentations, the PowerPoints, additional articles, and hopefully be a useful resource for all of you. And it will be, we know that there's a lot of use after this webinar as a resource, and you can share that in your own networks, obviously, as well. And finally, I want to say that our next international English webinar will be on the 25th of May, and will be on the topics of the dynamics of school health promotion. So another relevant topic, I guess. Thank you, everybody. Have a good day, evening, night, morning, wherever you are around the world. And thank you very much.